for the, very good, thank you. Good afternoon, everyone. Welcome to Augsburg. It's spring, perhaps, huh? What do you think? Yeah, we need it. So welcome to the Strommen speaker series here today at Augsburg. I'm Ken Holman. I went to Augsburg. My hair is a little gray. Do we have to divulge the year? Okay, I will. 1974. My father-in-law was the dean here for many years, Ken Bailey, and my dad taught here for a bit. So my wife and I both graduated from here, so a lot of strong ties to Augsburg over the years. I'm an anesthesiologist, and I currently work with Mary and all the fun things that we do in healthcare, and it's really a delight to be in healthcare as a profession. So for you students out there thinking about healthcare, 2 thumbs up. It's not easy, it's a lot of work, but a lot of gratitude in what we do. The purpose of the Strommen series is to really talk about leadership and enrich student and alumni experiences around leadership. As you know, this series has been here for about 4 years now, and other leaders that have been here have included Sally Smith from Buffalo Wild Wings, and Doug Baker from Ecolab, Mary knows him well, and of course Richard Davis from US Bank Corp. So good folks coming out from the community leaders talking about leadership and their expertise. Thanks, of course, to the Strommen family. Bob's here. Bob's folks, Clair and Gladys, were longtime supporters of Augsburg. Bob just came back from Florida where you saw your mom for a bit, and we are thankful to the Strommen family for supporting this series. The guest speaker tonight is Mary Brainerd, CEO of HealthPartners, Mary certainly is a national expert in healthcare, but more than that, she's a fabulous leader. So I think for you students out there, pay attention to what she's saying. So why healthcare is a topic today? Well, I think all of us know that healthcare occupies really a remarkable and unique space. From a global perspective, we see famine, we see war, we see poverty. The Gates Foundation, the Buffett Foundations have committed hundreds of millions of dollars to addressing healthcare issues around the world. Of course, it's a national issue. We see it played out in the politicians. It's 18 to 19% of our gross domestic product. We have significant populations that are underserved or insured, excuse me. And I guess that it is best to say that we have very passionate people on the right and on the left. Very passionate people, and that is one of the challenges of healthcare reform. It certainly occupies space in our state budget. We have a lot of issues around, again, uninsured populations in our state. And it is a challenge that in some ways does not get better. It gets worse as our state budgets are challenged. It occupies a remarkable space in our capitalistic environment in the United States of America. Healthcare is very important locally with its Medtronic and 3M and St. Jude. You list the companies. Conversely, healthcare premiums are a major cost of doing business for American companies, and as we try to stay competitive. So healthcare occupies a really unique space in our capitalistic and business framework. Certainly, it's very personal. Each person here was born. Each one of you is going to die. In between that space, there's a remarkable opportunity for you to spend a lot of money on healthcare, for you to have a bad experience in healthcare, and for you to have a less than optimal outcome in healthcare. On the flip side of that, there's also a remarkable opportunity for you personally to invest in a lifestyle that helps avoid cost, poor quality, and a bad outcome. So part of Mary's conversation will be about personal accountability and how we really engage the population in a different conversation around healthcare. So no surprise, healthcare's a hot button. Everybody's talking about it. The recent legislation, the Accountable Care Act, was passed. It introduced another acronym into healthcare, like we need another one. It's like the military, ACOs, Accountable Care Organizations, and what does that mean? Several fundamental changes for students. You're covered until you're 26. Hurrah for that. And several other changes in terms of federal legislation. that Mary will cover. Oddly enough, this all occurs in the face of several macro trends, increasing diversity in the U.S. Folks are getting older and living longer, so we can spend a lot more money on healthcare. Tremendous increases in technology. You all know them, electronic health record, all the different advances in cardiac, neurological sciences. Certainly globalization is important. And one of the perplexing things is historically, in many respects, a lack of engagement by key sectors in what's going on. People, companies, even health delivery organizations have been typically unengaged in trying to prevent costs in healthcare, and hopefully that is changing. So Mary Brainerd is our guest speaker tonight. It's a delight to introduce her to you. Mary has been Chief Executive and Officer at HealthPartners, and HealthPartners has really blossomed under her leadership. We now have 21,000 employees, and in some respects you could view our organization as having kind of 3 bins of work. Certainly a health plan that covers about 1.4 million members in the state of Minnesota and Wisconsin and a couple other areas. Secondly, we're a care delivery apparatus. We have a number of hospitals and 1,600 employed physicians. And the third part of what we do is all the support structure around that. Dental clinics, other health promotion, etc. So we are quite large and quite diverse organization. Mary's been with HealthPartners since 1992. We've had record growth. It's a great organization to work for. It's okay that Mary didn't go to Augsburg. I think, right, Mary? Mary got her MBA from the University of St. Thomas. So I'd like to welcome Mary to the platform for a really engaging conversation about healthcare. Thank you.
Well, hello. I'm glad to be here, and I appreciate the honor of being invited to speak with you tonight. And actually, I hope that we can keep the conversation informal. Actually, most of all, I hope it can be a conversation. So I'll tee up some thoughts and ideas, but I'm very interested in engaging with you in a discussion as we go or when we finish, whatever works best from your perspective. So Kenny's point in his introduction is such an important one. Not everyone in this room is a healthcare professional. Some are maybe thinking about it, maybe some clearly are. But the fact is, every single person in this room is an agent for change as it relates to health, your own health, the family that you live with, and in our community. And so if there's one theme to take away from the discussion tonight, it would be we need the energy, hearts, minds of every person to create a community of health, a culture of health for our future. And it's not just about, will I avoid my heart attack or will I be able to not have the stroke? It truly is about the health and vitality of our children and our children's children in the community that we live in going forward. So I was asked what I wanted to call this discussion, and I think people are thinking so much still about healthcare reform, the Affordable Care Act. I actually choose not to call it Obamacare because I think that diminishes it. I do want to comment a little bit about some of the elements of reform, but if we stop there, we haven't accomplished nearly what we need to in terms of creating a healthy environment for our future. So what's happening now? Well, in really straightforward terms, what is coming to life under the Affordable Care Act is first coverage for all. That includes a mandate that every individual have health care coverage, and there's some, and actually not hugely substantial in the scheme of things, penalties for people who don't. So that's coming to life. New distribution systems. So it used to be that distribution of health care coverage was through employers, through brokers and agents, starting to be more online. But the new distribution method will be through exchanges, and Minnesota will have an exchange of its own come 2014. Subsidies will be expanded. In the past, we've had coverage made available for people under Medicare and for those who couldn't afford coverage at all under Medicaid. Now I view it more as a sliding scale. For individuals and families who need help just purchasing their coverage, there'll be sliding scales of subsidies to make sure that that happens, and it needs to happen. If we're going to require people to have health care coverage, need to be able to afford to pay the bill for the coverage. And finally, there are lots of elements of market regulation, what that coverage is going to be, what benefits are included in the coverage, some limits on what the premiums might be for the coverage that's made available, and a lot of discussion going on about what that looks like both at the state and federal level. That's insurance reform. Interestingly enough, in a place like Minnesota, we've already had a lot of market regulation. So one of our challenges is where federal regulation interplays with state regulation, and I predict some of the disruption and discombobulation that people will experience. I shouldn't even use a word that diminishes it. There will be people who are disadvantaged when the exchange comes into place simply because Minnesota rules for how we operate going forward aren't the same as the new federal rules. That's a different situation in a place like Texas that has had no market rules. Completely different set of issues. So a lot of the challenges we face here are figuring out how to make the pieces fit together. I think there are good things about the health insurance reform that's occurring. Really think it's important to have people have coverage. The system before still left too many people out. But insurance reform does not make healthcare more affordable. Insurance reform doesn't address the future of healthcare. And so while there are good things and bad things, and Kenny's right, the politics around this are enormous, the fact is it's simply not enough. So what's needed most is actually better health and health care reform instead of only insurance reform. Now, the Affordable Care Act did include literally hundreds of elements to start to drive changes in payment approaches and to start to incent quality, not only volume, in recognizing healthcare outcomes. So, for example, you see a lot of articles talking about readmission rates. Do patients go home from the hospital and then not get any support and end up getting readmitted to the hospital? Those are some of the kinds of quality measures that were built into the Affordable Care Act. Starter set, they will evolve, the measures will get better, the measurement itself will get more sophisticated. So starter set, but the bulk of what's happened is under that term insurance reform. So what do we need? Well, the shorthand name for this is Triple AIM. This literally is the HealthPartners strategic plan, together with a fourth element that we put under the title People, because healthcare is still fundamentally about relationships. Relationships in exam rooms, relationships in hospitals, relationships among teams of caregivers with patients and families, but it is a relationship part of our economy. But what do we need? We need all of these things to happen at once. We don't have the choice of saying, well, we want improved health and we don't care how much that costs, because healthcare is being priced out of availability to the market. We know that we need an improved experience for the people that we serve. I've had such an up afternoon. I spent a good part of the afternoon today at Methodist Hospital looking at some of the work that's going on patient and family-centered care, some of the redesign that's happening so that patients can be much more engaged in building the care the way that will work most effectively for them. That's about the experience of care. Still, too many dropped balls, too many missed connections, too many times when people leave the hospital, don't know where to turn next, too many safety risks, too many misused medications. Around the improved experience of care, better health, and more affordable care, we need it all to occur. Now, I have a lot of critical things to say about healthcare, but I also want to, before I even do some of that, I want to be really clear. If you can't see that very well, what this is the Commonwealth Fund report looking at communities across our country and how they rank in terms of quality, access, and affordability of care for people in the Medicare program. And St. Paul is number 1, Minneapolis is number 4, St. Cloud is number 7, and of the top 10 in the country, 6 are in Minnesota. So when we look at Minnesota compared to other places in the country, we are at the top of the list. And lots of studies look at the United States and our health outcomes compared to other countries. And you'll read, boy, the US doesn't look very good when it comes to infant mortality, or the US doesn't look very good when it comes to chronic illness care. Well, Minnesota actually compares very well with Scandinavian countries in terms of health outcomes and value. So I want to say, to begin with, we come at this from a position of strength. We're doing a lot of things right here in Minnesota, but we're still doing some things that could happen better and more effectively. But I would argue that that result doesn't come by accident. I think it really comes as a result of a lot of the work that's going on, not only in organizations like HealthPartners, but others across our community and state, by some of the work that's gone on in the public health system that I think has been effective, and still more to accomplish. So why take so much time with this? Well, because health still is at the top of the list for most people of what matters most in their lives. When it really gets down to it, people will say, thank God I've got my health. Or I may not have this, but I've got my health. And anyone who's received a life-threatening diagnosis knows nothing takes a higher priority in your mind than getting your health back when you hear that tough news. And it also has a big impact, overall health, on what we can afford in healthcare going forward. And we're currently obligating ourselves to some things that are going to be tough to pay for in the long haul. Now, the next is my only really nasty looking chart. What this is, talks about public spending and the entitlement programs that we have in our country. And that bright blue piece is what our current entitlement programs under Medicare, Medicaid, Children's Health Plan, and the exchange subsidies, how much of our federal government spending that will consume. You can see Social Security, which for so many years was called out as we can't afford to have the Social Security system we have today, really not on that same trajectory. The challenge here is all of the other areas get squeezed out. Investments in education, support for other kinds of services, social services, all the other things we as a country want to invest in has the likelihood of being squeezed out by the commitment that we're making to pay for health care when health care spending is pretty much out of control. There's an article in the New York Times today that called out the fact there's agreement, it looks like, on one topic between Republicans and Democrats in the federal government right now, which is for every dollar that American citizens pay in for Medicare, they're taking $3 out. And that's the challenge of addressing health and healthcare costs in the longer haul. So, to improve health, healthcare, and affordability, I think we need to do a few things. One is we need to make sure that we have payment approaches that support those aims. And that simply has not been the case in the past. We have a healthcare payment system that came out of post-World War II up to the early 60s when most healthcare issues were crises. They were acute care problems. They were conditions where you might have them, but if you did, you either lived or died, and it happened pretty quickly. So you could afford to pay for process. Let's pay for the process because it's pretty defined, beginning, middle, and end. The challenge we have now is 85% of healthcare is chronic illness related. So we have a payment system designed for a different kind of healthcare than the healthcare that's being delivered today. So the change we're looking for is from the old model of paying for the more you do, the more you make, to payment to care delivery organizations who are willing to take some risk and be held accountable for quality, experience, and affordability. That's a work in progress. This alphabet soup that Kenny referred to of accountable care organizations is one idea the federal government has, and the alphabet they assign to having organizations take some accountability for their healthcare outcomes. You could put a bunch of different labels on it, but the idea is all the same. We can measure quality now, didn't used to be able to do that. We can measure healthcare results better. Let's start paying for that instead of only paying for process. I see this really all the time in our work as we look at services that sometimes have value and sometimes don't, like spine surgery has gotten a lot of attention recently. About half the time it's helpful, the other half of the time it's not, yet we pay, the more you do, the more you get for spine surgeries. And it's really hard for medical groups and hospitals not to want to do spine surgeries when that's a place where there's a lot of profit. So aligning with good outcomes, the results we want to see, instead of just paying for procedures, is a big change that I hope is ahead. And to do that, we need really good measures of quality and safety and affordability. That's been a challenging one. We need to figure out the best ways to incorporate patients' and families' experiences in the healthcare system and those healthcare outcomes. Again, Minnesota's a leader. We already have an organization that does that called Minnesota Community Measurement that publishes healthcare outcomes. There's one other state in the country that has that kind of a collaborative place where we've agreed we're not going to compete over the definition of quality. We're going to agree that it's important to get started. It's important to start engaging our work around quality outcomes and start making that publicly available. HealthPartners has contributed something to this. It's the only advertising I'll do in this, and it's, I think, a good one to advertise. We created a measure. Who would have thought one of the coolest things you do in a 2 or 3 year period of time would be to create a measure of affordability? But we created one. Actually sent it through about 1.5 years worth of statistical of testing. The National Quality Forum said, you know, this is a pretty good measure. It's pretty sophisticated. It takes into account things like risk adjustment and differences in populations. And the cool thing is, if we're going to pay differently and we want to pay for more affordable care, at least recognize that in our payment systems, we got to start using it. And the neat thing for us has been we make it available, licensed for free, so we haven't turned it into a product or to make any money off of it. But there are now 50 different organizations using our total cost of care measure of how can we make healthcare more affordable in 20 different states and more that have just taken the idea and run with it. And some of the places it's being used are pretty cool too, like Dartmouth, which is doing some of the best work in the country in focusing on how are we using our resources to make sure we get the best health for the people that we serve and that it happens at an affordable cost. And they're also sort of the go-to experts for Medicare. So we're pretty excited about how it's being used at Dartmouth. The state of Maine is starting to use it as they implement the Affordable Care Act in their state. We've been using it in the way that we contract with doctors and hospitals, and now about 85% of our members receive care from an organization where that affordability measure is at least part of the record of success. And we see it in a changing cost trend. And the reason the tall bar isn't there is it's not available for 2011, which says something about how quickly we report results in healthcare. That's the national benchmark trend. But our trends have started to change substantially, and I can tell you for 2012, the healthcare cost trend looks like 3 again. Now, do we wish it was 2? Absolutely. But the fact is, we like the idea of getting healthcare costs much more in line with the overall increase in the consumer price index, because that big Medicare slice of the federal costs will be impacted whether if it's 2, it's going to be better than if it's 3, it's going to be better than if it's 6%. So I've been talking a lot about financing, which might not be the most interesting part of healthcare, and it certainly probably reinforces a stereotype, if anyone has it, that a health plan person only cares about the money. And that's not true. But if we don't have payment that aligns with the things that we want to get out of our healthcare system, it's always going to stand in the way. So I mentioned that first, but what's really important is changing healthcare requires that aligned payment, but more important, it requires redesign of the healthcare itself. And some of the very impressive things that are happening, and I'm not speaking only about HealthPartners at this point, is, as I mentioned, 80 to 85% of healthcare is chronic illness related. Number one cost in Medicare is diabetes care. And the sad challenges associated with diabetes is that many people also get heart disease, get eye disease, end up with amputations, end up on kidney dialysis, which is really a horrible life impact. So some of the ways that healthcare itself is changing, new ways to deliver care. I remember Richard Davis once saying, from US Bank, saying that his mom still wanted to go to the branch bank at least once a week, and she knew the teller by name, that he wanted to do a lot of his banking on the phone, maybe when he was driving, and that many people in the next generation will never set foot in a branch bank, and they'll do all their banking online or via mobile. Well, healthcare is a little behind that, but we're headed the same direction. Every element of healthcare doesn't require time wearing a gown in an exam room. So much more can happen through proactive teams of care, using health professions to the full capabilities of their licensure. So much more can happen online. A lot of healthcare is information exchange, and there are lots of ways to get information capably into the hands of the people that we want to serve. Out of all that, new roles for nurses, pharmacists, mental health professionals. I had the pleasure of sitting in on a team visit between a primary care doctor, a pharmacist, and a Russian-speaking patient at one of our clinics just down the street off University Avenue. And the patient had had very difficult time with diabetes for a number of years. She was currently taking 9 medications. She was just on the borderline of needing to get ready to go on kidney dialysis, and she'd had uncontrolled high blood pressure and had a tough time communicating, 75 years old and pretty overweight. So lots of challenges from the physician's point of view. And it was really interesting to see the physician and the pharmacist working together, then the pharmacist taking an additional 45 minutes of time to really unpack the patient's experience of using her medications. Which ones was she taking? Which ones was she not taking? Why? Were there any risks to some of the upcoming procedures she was going to have? It required that kind of an investment of time and energy, and actually information that was most pertinent to her care, and making sure that there were plenty of follow-up contacts, by the way, over the phone for this particular patient, with the pharmacist planned and scheduled for the upcoming weeks. That's a different pharmacist than a pill bottle filler. And we're redesigning and seeing others redesign the visit to include a much different clinical interaction with the nurse, as well as with the physician. New interactions and partnerships at work, at home, online, mobile. A lot of interest in having clinics at workplaces, where people with chronic illnesses can get their support from a nurse practitioner or a physician assistant on site, making it easier and more convenient and very appropriate way to actually benefit people, lower cost options, and increased productivity from the employer's standpoint. And finally, focusing support and partnerships with individuals experiencing chronic illness. And this is currently my favorite picture. Recognize this place? This is where Minnesotans go to express their non-healthy lifestyle. But instead of healthcare systems that wait for patients to show up, treat patients in an exam room for what they're there for today, the new model is focused much more around us thinking about, and this is an old slide, this is an old HealthPartners slide. With Park Nicollet together, we have about 30,000 patients who are experiencing diabetes. We need to think about those 30,000 patients not just when they show up in our exam rooms, but between visits, before patients walk into our exam rooms so that we anticipate their needs. We can reach out electronically, communicate, share results without requiring a visit to be the center point. We can support our patients more effectively in using medications, and I just gave you an example of that. But it means thinking about not patients as sequences of visits in exam rooms or hospitalizations. It takes thinking about, and frankly, using electronic health information as capably as we can to think about our patients all the time. Because that's really what it takes to offer support to people with chronic conditions. Another example, we know that 25% of our patients who are on Medicaid have a mental health diagnosis. Really important example of a place where medication support is appropriate, where when a patient comes to an emergency room in crisis, it really benefits our patient support and our results if we can make sure there's a connection to a primary care team or to a mental health team. Also speaks to the importance of being capable of providing mental health services in emergency rooms, not treating those too just like isolated care examples. Again, our numbers about doubled. Currently we have about 4,000 frail and elderly patients who are taking more than 16 prescriptions. Another example of the place where there's really an opportunity to support making sure that the patients who are the most frail, the most fragile, get the support they need to live a good quality life. And finally, 1% of our patients represent 25% of healthcare costs. If there isn't a case there for an investment in having a resource that can make sure that patients do get the support they need to avoid the emergency room visit that could have been averted, or the hospitalization that wouldn't have had to take place without a missing test, a missing specialty visit, or a missing medication. So a completely different way of thinking about the way that we provide care, a different way of using health professionals as team members, and a different way of partnering with patients, understanding that we can use technology to be our friend and to be the friend and partner of the patients that we serve. Chronic illness. If the American healthcare system is really about chronic illness, boy, incidence of chronic illness and severity of chronic illness is inextricably linked to our lifestyles. It's inextricably linked, maybe more, to being at the state fair than to what happens in the exam room. Let me give you an example. This is my other chart. This was created at the University of Wisconsin. It talks about what affects length and quality of life, so morbidity and mortality. And this research would say that clinical care, what happens in our hospitals and doctors' offices, while incredibly important when you have a health crisis, really only affects about 20% of length and quality of life. Another 30% of the impact has to do with health behaviors, specifically tobacco use, diet and exercise, alcohol use, unsafe sex, and then 40% has to do with social and economic factors like educational success and attainment, the percentage of people in a community who graduate from high school, whether or not people have jobs and whether they're decent jobs. What kind of incomes do people have in the community? Do they have healthy neighborhoods? Do people own their homes? Do they have family around them? Is the community safe? 40%. And then physical environment, 10. So when we look at this and see clearly an organization like HealthPartners needs to take very seriously, the most seriously, the places where we have the greatest control and impact. So for us, that's clinical care. But boy, if we stop there, we're missing 80% of the picture. And I don't care if 20% is wrong, maybe it's 30, maybe it's 15. We can't afford to do that. So we look at health behaviors. We need much better methods, and we have created some, of partnering with our members and our patients around healthy behaviors. In fact, we started measuring this a few years ago. And we had a little different measure. It was diet, meaning 5 fruits and vegetables a day, exercise 30 minutes 5 days a week, tobacco use, meaning not using, and alcohol use, meaning moderate alcohol use, on an average 7 drinks a week for a woman, 14 for a man. What do you think, what percentage of the population do you think that we serve? So, pretty much an employed population, some public program members, but pretty representative of Minnesotans. What percent do you think we're doing all 4 of those things? Got any idea? Okay, I hear 10. We started at 3. We're up at 10 now. The hardest actually to accomplish for people is eating fruits and vegetables. One of our cardiologists was telling me he had a patient who was like, how can I eat 5 fruits and vegetables when there are only 3 meals in a day? So, we make it really hard for ourselves to do the basic things. The reason that little group of health behaviors matters, about 40% reduction in incidence of new chronic conditions based on whether you're doing those things or you're not. Biggest predictor of unaffordable health care costs in our country, whether we do those things or not. I spent a lot of time on payment systems, but I'll tell you, even payment systems and care delivery changes are tiny in comparison to how we live our lives in our country and what we're doing to set the stage for the future. Social and economic factors, I don't want to walk away from that because I actually think that's part of maybe why Minnesota looks so good in some of that Medicare analysis about resource use and quality and effectiveness. We're lucky. We're one of the places that's had a relatively healthy economy. We've been a pretty thriving community. We have been a homogeneous community, which is maybe why we, in the past, have stacked up pretty well to places like Scandinavia. But our community is changing, the economy has changed, our environment has changed, and those organizations like Augsburg and HealthPartners that are geographically committed to this area need to pay attention here. Education, employment, income. For me personally, it's one of the reasons I've invested a lot of time and effort in an organization called the Itasca Project that's looked at disparities, that's focused on education policy, that's looked at economic development and job growth. I don't see that as outside my job. I see that as very connected to the work of my organization. And the fact is, don't have very much control there, but we can be great partners with other organizations in trying to address that 40 or 50% of the drivers of health in our communities. So I think it is a big deal. Many of you have seen this before. This is the map of obesity in our country. And you can see back in the 1990s, it was all blue, less than 10%, less than 14%, went to more states hitting 20% of the population obese, and that's a BMI of more than 30 or 30 pounds or more overweight. And now you can see how things look in our country. Minnesota, again, looks terrible, but not as terrible as some other places in the country. And this looks to have plateaued maybe in the last couple of years. Those numbers don't seem to be creeping up at the rate that they have been over the past 20 years. But it's really important. And so we need to see that change. I mentioned those 4 healthy lifestyle behaviors. One of my favorite YouTube videos, if you haven't seen it, I hope that you do. It's called 23 and a half hours. And it's a presentation by a physician who talks about this one thing that if it was a pill, every person in our country would either be on it or demanding it. But because it's not a pill, it's really hard to sell, and you know what it is? It's a half-an-hour walk a day. You don't even have to do it all at once, and you can do it in 3 segments. But the impact in avoiding future disease, in mitigating existing chronic disease, in feeling good, in avoiding depression, in avoiding cancer, in postponing diabetes has been documented over and over and over again. So when I talk about things that we as agents of health in our own communities and our families and our own lives, we have control over this. Not perfect control. Built environment plays a part, very important part, but it's certainly something each one of us can do for ourselves. And frankly, it just blows my mind that me taking a 30-minute walk a day can create an affordable healthcare system for my kids and hopefully the kids that they have someday. So it's a good twofer. I also just thought I would mention some of the things that we've been doing to redefine that relationship with the communities that we serve, with the people that we serve, and some of the initiatives that I know many of the people in the room are interested in disparities of all sorts, trying to address those and change the picture in our community. Well, for me personally, the work that I did with the Itasca Project on disparities overall in our community, race, income, and place-based disparities, has helped me understand how deeply committed we need to be to changing health disparities as well. So we had a project over the past couple of years called IBAN, and chartered 9 interprofessional, so changing healthcare teams across our organization, involved community members in every one of those initiatives, which in and of itself was a learning for our caregivers to work differently with people in a changing community, with a focus on improving care systems, using some quality improvement approaches, including lean, and then also working to achieve reductions in some of the disparity gaps that we saw. And we feel like we've seen some really great things happen. The teams have been focused on, in fact, one right across the street, Riverside Clinic, focusing on pediatric immunization rates and working with people from communities in West Africa, which have had no experience of immunizations, knowledge of benefits, and so quite a bit of community interaction around that topic. Working with Ethiopian patients on diabetes health outcomes. I won't go through each one of these. Colorectal cancer screening for our patients of color, some very different issues based on your race and ethnicity relative to the appropriateness and willingness to tackle colon cancer screening. And in dental, making sure that little tiny kids, toddlers, get a start on dental sealants at a time in their lives when it can really make a positive difference. One of the things that's fun about that is pediatricians and pediatric nurses are actually doing the dental sealants at the well-child visits to get kids that nice, healthy start. So our aim, I think, for all of us has got to be, we all play a part in whether we have a thriving community. It's really a big deal. Everyone here makes a difference in that result. Supporting those healthy behaviors and lifestyles, that 23.5 hours a day, it really is about what each of us can accomplish in creating that healthy future. We can make sure that care is safe and best science is delivered reliably. Just one more story. People sometimes wonder, can groups of consumers, can regular people make a difference in healthcare results? Not just the walking, but actually changing healthcare results. The highest impact group of patients I've heard about or understood in a while is a group of people from Cincinnati. So they were parents of children who had cystic fibrosis. Good advocacy group, and they could see their kids weren't doing that well. And Cincinnati Children's Hospital said, you're right. Kids aren't doing that well here. We've got to figure out how we can do better. How kids with this illness can survive longer in our community, and how we can do a better job of, again, a chronic illness, supporting kids with this chronic illness. So to make a long story short, they found out that the Cystic Fibrosis Society had information on health outcomes from all over the country, but they wouldn't let anybody see it. So the parent advocates were able to convince the Cystic Fibrosis Society to share those set of results. And in sharing them, it became obvious there was one place in the country whose results were head and shoulders above the rest, and it looks like at least part of that was due to effectively working with adolescents who had the disease. And that place is the University of Minnesota. Way better results than any place else. Only nobody knew, nobody shared the information, no other places could learn from the practices at the university until the group of parent advocates forced the change to share the information. You know what now? Results for kids with cystic fibrosis are improving across the country as the result of that one powerful change. So, safe care, best science delivered reliably. When we know it works, we got to do it. And it still doesn't happen enough in healthcare. We still have a lot to learn and a lot to put in place and a lot to overcome in terms of professional autonomy needing to be subservient to best patient outcomes. We need to do a better job of partnering patients and providers and consumers because chronic illness care is about health behaviors. So we gotta have health caregivers that are actually great team members who understand behavioral science, who are able to stick together and be the support network for patients who are truly living their own lives and will be making a lot of the decisions that relate to their health outcomes. We need that aligned payment system, and we're getting there. It's just that we're getting there awful darn slow. Like to accelerate that, that's why we've been working on measurement, and I'd like to see that part pick up the pace. And then, there's a little typo there, we need public information about those results. Like the example from Cincinnati Children's. People need to be able to understand what they're getting when they come into the healthcare system. So that's what I think real healthcare reform looks like. I'm glad we're doing insurance reform. Not every bit of it's going to be easy. I'm sure there are going to be many painful days ahead for both consumers and families, but especially for health plan organizations like mine. There's definitely going to be some rough sledding, but it's the right thing to get everybody covered. And we really need health and healthcare reform. So with that, I'm happy to answer any questions you have or discuss any of the topics that you want to raise. Thank you. That is a hard question to answer. I don't know if it does, but I know for sure we're wasting a lot of resources in our systems today. We're paying for a lot of things because of the way the payment methods work today. The more you do, the more you get. And I believe those healthier lives would have a bigger impact. I'd rather try all those things than think that we had to go to rationing first. And in fact, you know, some of the tougher discussions are around end-of-life care, because as Americans, we have a slide that just blows me away. It shows every other country and the United States spending about the same up until age 58, when U.S. healthcare spending per capita goes right up the chart and every other country stays flat. Now, why is that? Well, that's probably when most people start experiencing the impacts of chronic illness. It's probably some differences in what kinds of care we make available to the elderly population here, and it's what happens at end of life. And there, too, I'd rather start with, why don't we ask people what they want? Why don't we have the courage to have those discussions about what do you want to have happen at end of life? They should be happening in churches, in community centers, in skilled nursing facilities, when people can still have a voice about what kind of care they want for themselves. And it's not going to answer every question, but in several rooms I've been in recently, when you ask people to talk about end of life, people raise their hand. Terrible experience for my mom. I wish she didn't have to go through what they put her through. Or I saw my spouse and I wish we could have made some different decisions. Or they took her to the emergency room and by then it was too late to stop the sequence of events that nobody wanted for my family member. And why does that happen? Because nobody weighs in ahead of time. So if we can figure out how to have those discussions, safe discussions, it isn't about doing less, it's doing what you want. And first having the discussions and then making sure that information can be used in the healthcare system, I think we would do a favor to a lot of people. I hear a lot more stories about, I wish it would have been different, than it was great. It was a great end-of-life experience. The great end-of-life experiences, you hear of that more, people who've experienced hospice, palliative care services. So I don't want to ration, personally. I don't want that for me or my family, but I sure want people doing what I want, what my husband wants, what our kids want.
Thank
Yes.
you for coming today.
You're welcome.
It's been very informative. What is your organization doing, or can your organization do anything to stem the message from the food conglomerates and the advertising sector to eat sugar, fat, and salt? I think our culture has been educated by these food conglomerates, and I'm wondering if you have any impact as an organization with that sector.
Boy, food companies tend to have a lot more money to put into advertising than healthcare organizations do. As for my own organization's example, we've been doing work with Minneapolis, St. Paul, Anoka Hennepin, Stillwater school systems to promote fruit and vegetable eating, and I can tell you we've had an impact. But that's only the beginning, and the hope is if kids start being more enthusiastic about fruits and vegetables at school, they'll go home and pressure mom and dad a little bit. And there's a little hope for that. You know, kids have played a part in, I think, in seeing tobacco use rates come down. Kids just tell people, I don't want to be around you. Don't smoke, Mom. That's been a powerful voice. But it's still a really tough one. I think it's very difficult. We did the ads last year with Andrew Zimmern, where he did the eating gross stuff, and the kids are screaming because he was eating the tarantula, and then we'd get them to eat broccoli. If that was just an ad campaign, I would have thought it was cute, but it was fortunately accompanied by something with quite a bit more depth relative to trying to promote healthy eating. There are a lot of people asking that question, and maybe that's a good thing too. Yeah. I don't think it is, it's a little bit of a red herring maybe. I think it's more a symptom of a defensive culture where people are worried about litigation. But tort reform, I think, first of all, I don't like to tilt at windmills, and I don't think it's going to be easy to get that one changed. But I also don't see it as a major driver. Maybe a little bit more on the East Coast, maybe some individual physician specialties, but I don't think it's the big driver of the picture that we see.
I work for a national reference lab owned by the University of Utah, and in our little area, so to speak, we focus on a philosophy of right test at the right time, the right economics on the right person. Could you comment and maybe give an example of some ways you've influenced utilization or units of care, so to speak, if you want to just make it as generic as possible?
Sure. Low back pain, a great example. That, as I mentioned earlier, spine surgery works for some people, not for others, can't predict ahead of time. So instead, there's every evidence that for many cases of low back pain, being able to get physical activity and physical therapy can be as effective as any medication or any procedure that's done. And we've both helped grow and foster programs that create those alternatives. I think probably nationwide, I don't know of anyone in any place in the country that's doing a better job of trying generic medications first. Not only, but starting there. And that's clearly a place where there's a ton of opportunity to save dollars for people, and especially people with high deductible plans, which is also increasingly frequent here in Minnesota. They want that information about what are my lowest cost alternatives that might get the job done effectively for me. You know, Kenny, can you think of one that? Oh, well, give it. You give that example.
So once you enter the acute care system in healthcare, the wheels start to turn. So a good example would be after you have a heart attack, damaged myocardial muscle releases enzymes called troponins. And so we've been doing a lot of work, and nationally a lot of work on what's the right interval to draw the troponins and what specific type of troponin. So our troponin use has dropped 50% in the last 3 years because we've looked at how we managed that lab test. Another good practical example is imaging, CTs and MRIs. The electronic health record has allowed us to embed in our order sets that reside in our computer so that the testing that we do is not at the whim of somebody writing a note with a pen and a piece of paper. It is based on the diagnostic algorithm for that disease process. And that's made a big difference. But your right test at the right time is just right on the mark, right on the mark.
Thanks. Yeah, that's exactly on the mark. Yes?
This is a follow-up both to the last question and also that comment. In urgent situations, there's oftentimes no information about an individual. You have a trauma hospital, you know this very well. Now, the idea of an electronic medical record sounds like it might be part of a solution to some of this, but they don't talk to each other. So unless it's your member, you don't have the information. Governor Pawlenty set a goal of 2015 for interoperable electronic medical records. Will that happen?
No, I don't think we'll get there by 2015. We're getting darn close though. And right now, in our market, again, Minnesota, a little distinctive, all the major organizations use the same medical record. And so we're able to talk to each other today. It's really a question of stopping long enough to make the connections and making sure you get patient permission. But it's happening more frequently all the time. It's a really good step, and it's another area where when I travel elsewhere and I hear that there's a debate about whether or not we should move from paper to electronic records, I kind of, because that was done here a long time ago.
Hi,
Yes.
Mary.
Hi.
Thanks for being here at Augsburg College. We appreciate you being here. It's a very interesting talk. I want to take you back to a couple of other earlier comments. You talked a little bit about end-of-life care and the consumption, the spending on health care as people get older, which is interesting. And I need it's just your thoughts about some demographic trends, because I'm a boomer, and I think that may be one of the biggest threats. We may be one of the biggest threats to healthcare right now. We've been voracious consumers of everything since we started. We turned obstetrics on its head, K through 12, higher education, the workforce, and now we're starting to retire, and we're realizing the cumulative effects of too much sugar and fat and all those kinds of things in all of our years. And I understand, I don't know the exact ones, you know it better than us, the spending on healthcare in the first 5 years of life and the last few months of life, and where that goes. And one of my worries is that us boomers aren't going to know when to go when our time comes. Because we've never known, all along. So I'm interested in your thoughts, because I think just that generational thing, and of course older folks tend to vote more, so we're going to carry a lot of clout over the next 20 years, 25 years, and the healthcare debate, where that spending is and where it is, and it's probably going to be misdirected. Having said that, can I get some of your feedback and thoughts on that?
Oh boy, I think you have raised an incredibly important point, because you're right, the boomers are, it's what, 10,000 individuals are turning age 65 every day. So we're going to swell the ranks of Medicare members, and we're going to swell the ranks with people who have chronic conditions at levels of incidence that haven't been the case historically. That's why we're going to put so much pressure on the future of Medicare and Medicaid. And I do worry that when we put so much money into healthcare, we're not going to put money into the other investments that we should be making as a society. It's why I feel like it's really important to step up to this challenge. And not all healthcare organizations feel that way. Mayo is a wonderful organization. They see their future as a worldwide destination for healthcare. That's worthy. It will add jobs. It's a benefit to Rochester. But that's different than saying you're an organization that thinks that triple aim, affordable healthcare and better health in our community, is what you're here for. So, and there are many healthcare organizations that are going to see it as their obligation to live with and take advantage of today's business model as long as it operates that way. And it means there are going to be more cardiac centers and more orthopedic centers, and there are going to be more spine surgeries, because those are the things you make money on in healthcare. And that will continue to roll out and add to costs without the changes that we've been talking about. So it's interesting. I think 10 years ago, I thought most healthcare organizations were kind of shooting for the same end in mind. We're not. No, for us, we're committed to this community, to that triple aim, to making healthcare more affordable, and we see the connection with a thriving community and the health of the people in it. And so those are the investments we're going to make. And I can't guarantee it's going to work out for us either. So there's a bet. Yes?
What do you think about paying medical providers and doctors only when they get the diagnosis right? A lot of times there's an experimental diagnosis of the prescription, that prescription, there's cost, there's a procedure, there's several visits. When I saw my grandpa get some misdiagnosis and was using stress and money costs them all at the same time. So I think healthcare providers and doctors sometimes the incentive isn't necessarily morally correct for the long term. And I think that, like other business models, pay for good performance. And I know it's kind of subjective with healthcare because performance is hard to measure.
So I think there's a little difference between, I after years of experience, see that medicine is both science and art. I don't think you get it right every time. I do think there are places where there's judgment call and uncertainty and complexity that would make it difficult to say you get it right or you don't get paid. On the other hand, I know that still too often we cause an infection. We operate on the wrong part. We, in the healthcare system, create that pain and suffering. And I think there should not be a financial reward for that, and there should be financial consequences for it. Our organization, Maureen remembers this well, we decided we weren't going to pay when somebody operated on the wrong body part. We weren't going to pay twice. And it was extremely controversial. That was, I don't know, 12 years ago. Medicare finally put that policy in place last year. So, you know, there's a lot of opportunity to line up the incentives better than they have been. But I also have really a deep respect for the complexity of medicine as well, and that it makes it a little harder to do just the straight line to outcomes. Well, I think there's still the place where, and Kenny gave a great example, diagnostic imaging, another area where there's a lot of profit, and oftentimes use when it's not going to make any difference to what the course of care is. So I think there are those examples. I just still don't believe that predominates. At least it doesn't predominate with bad intention.
Well, if it did, then it's criminal.
Yeah, that'd be even worse. Yes?
You talked about the new roles that you'll see with doctors and PAs and patients.
Yes.
You didn't really give any specific examples, and all I've heard and kind of experienced for myself is shorter visits, quicker, one complaint in and out. Can you expound on some of those roles, the new roles that we're going to see with this act? Sure.
So more and more we're seeing PAs and nurses are actually running the worksite clinics, for example. We now have 10 or 11 work location-based clinics where nurse practitioners and PAs are the resource, providing support to that work population, and in some instances families for that workplace population as well. So that's one. In our case, we have a really exciting little product called Virtuel. You may have seen on billboards or alternatively on the back of bathroom doors, saying care for 40 common conditions. It's all nurse practitioner based. While there are algorithms that are used either online or in a mobile device, in the back of all that is a nurse practitioner creating a care plan, doing follow-up with patients. We see that changing. See the role of the nurse in expanded time visits in a primary care locations, so that a physician may do 15 minutes on the front end and 5 on the end, because the usual physician time is about 20 minutes for a visit in our system. But in between is, again, time with a nurse that's more in the 45-minute range. And sometimes they do it the other way. The nurse will do the opening and the close, and the physician time will be in the middle. So we're trying all of those alternatives, clearly more connections, video connections with specialists that can provide more direct support to primary care and to nurse practitioners. So those are some of the examples that come to mind quickly. And I gave a bunch of pharmacy examples because those are like no-brainers.
Hi. My question kind of builds on the gentleman's from the front that we talked about before, but with the Healthcare Reform Act specifically, it's going to be a lot of reimbursement with patient compliance and improvement in patient health in general, but how do we prevent that from becoming like the No Child Left Behind Act, where it's a great idea and it's fabulous, but it's really just not practical, and you can't really control whether a patient is compliant and if they're going to quit smoking after that surgery, which is a huge influence on their recovery. So how is that going to impact future healthcare providers, and with their increased burden of caring for their patients and motivation for caring for them, how is that going to impact the reimbursement? And I don't know, can you expand on just the fairness of that?
Oh yeah, so I think your point is an important one, and we struggle with that. Regions, trauma hospital serving a very complex patient population, many low-income patients, and so readmission rates, really you're going home to a place that's not able to support you effectively in getting healthy, and we're going to get dinged on a readmission that occurs because of that. And I'm a little bit more in the mode of imperfect measures, good place to get started, still the systems that we build to try to support patients so that we avoid the avoidable complication or the outpatient care that is not adequate to support patients well. I'm willing personally and for our organization to, I don't actually have a choice because it's in law, but I'm willing to feel like, yeah, that's work we should be doing anyway. The point that you're making, though, about patients with chronic illness is important. I think we will end up moving away from words like compliant to more partnerships with our patients, to more of a not a parental relationship, because for sure, telling people with chronic illness what to do, it's just not successful. So I see more opportunity in behavioral science. I see more opportunity in culture change. You look at places where we have achieved changes in not that long a period of time. I remember as a kid, people didn't want to wear seatbelts. People wear seatbelts now. People smoked. People don't smoke so much now. People had a drink at lunch. Who has a drink at lunch? I mean, there are a lot of things that have changed in terms of our culture, and I think we need a both and. We need to change our care systems, we need to change the way we relate to our patients and our members, and we need cultural change, like about healthy eating, I think, to get where we want to go. And I believe Minnesota has got as good a chance at doing that. We had a Mississippi, so we got a good chance at this too.
Mental concerns that impact the physical manifestations, and that I've also had conversations with people that our mental and emotional states affect our physical diseases or dis-ease. So I'm curious what you might share with us more about what HealthPartners is doing, or what your thoughts are on that more holistic nature of health and helping people become more healthy.
Yeah, in the East Metro, Regions is the major provider of services for people who have serious mental illness. And what I've come to learn over the past many years now is, first, we do not do a good job of talking about mental illness. We don't do a good job of intervening to provide support and treatment until often people are well progressed into a disease so that it has disrupted family relationships, jobs, stable living environment. So we get involved when there's a crisis, and it could have been avoided by tackling it earlier. We have healthcare givers still that are uncomfortable with mental illness. And I understand why. We had a patient come in and attack a physician in one of our primary care locations about a year ago. And the discussion at that clinic afterwards was, maybe we shouldn't be serving those patients if we have to be at risk. And so it's those patients with those diseases. And so we're not, I think, immune in healthcare from having our own stigma associated with mental illness. So I think we got more conversations, more getting it out into the open, more early diagnosis, more effective treatment, still more connecting mind and body, as you point out. Our dental director says that's true about dental care too. He's like, people forget the teeth are part of the body. We think in segments and body parts, and that's a disservice to the people that we serve. We've been trying to redesign the way that we deliver that care and engage families and patients much more directly in how we provide some of that care. But last week there was a discussion in the federal government about segmenting out in the electronic medical record mental illness from physical illness. So, it's still a big challenge to treat people as whole and without stigma.
Maybe you can see why I like to work for HealthPartners. This is a Augsburg sweatshirt for Mary. She's an honorary Augsburg. And so, I spend my day working with hospital executives and physicians, and so it has been helpful for us to close our sessions with 3 takeaways. And it's 3 because there was a study in 1956 that said that the average Iowan can remember 3 things. And I always tell our hospital executives and physicians that hopefully they can hit the Iowa standard. So I'd like you to take away 3 things. 1, in order to deliver on health care improvement in this country, we need your personal engagement in what you do. Your personal engagement in your behaviors, your personal engagement in your lifestyle. Number 2, healthcare reform by nature is part of a legislative process. Representative Sabo knows that better than any of us. The dollars spent on healthcare at the state and the federal government level are enormous. We need your engagement in this political process very badly. And make it less be about politics and more about what's the desired outcome. And the third, I hope you got a view of HealthPartners, and in the context of our 21,000 employees, our 1,700 physicians, our 7 hospitals, 1.6 million health plan members, as a nonprofit organization, that this is what we do. This is our passion, this is our mission, this is our vision, and as a student, boy, what a great way to spend a career. So I'd say thank you again for having us here today. There is pizza, by the way, with Diet Pop. in the Christensen Center, second floor, right over there. Again, thank you very much.